Okay, welcome everyone. We'll just give it a minute or so for people to jump in. Hope you're all having a wonderful Tuesday. And we're really looking forward to sharing this webinar with you today. Okay, it looks like the numbers are starting to stabilize. So, good afternoon, everyone, and thank you for joining us. My name is Steph. I am a research fellow at the Matilda Centre for Research in Mental Health and Substance Use, and I'm project lead of Cracks in the Ice. And it's my great pleasure to welcome you to today's webinar. Before we begin our webinar, I'd just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water, and culture. I'm currently land of the Gadigal people and pay my respects to their elders past, present and emerging. I'd just like to further acknowledge the traditional owners of the country on which you are on and pay respects to their elders past and present. And if you would like to put in, I'm sure our presenters will also mention what lands that they are joining from us. So today's presentation is one in a series of webinars. For more information about Cracks in the Ice, if you haven't already visited the website, I would encourage you to do so at cracksintheice.org.au. And we welcome any comments or questions that you have, so feel free to get in touch with us. Before I introduce you to today's speakers, I just want to let you know that you are in listen-only mode, and that means that we can't see or hear you. But you'll notice that you've got a Q&A button on your dashboard, and this is where you can type in questions that you have throughout the webinar and send them to us, and we'll have a dedicated question and answer section at the end of the webinar. We will also be recording today's session and making the recording available to you via the Cracks in the Ice website. So we have three fantastic presenters today. Dr. Shelley Walker, Dr. Michael Curtis, and Emmanuel oh no, I already forgot how he told me to present it. Mamiotti from the National Drug Research Institute. So Dr. Shelley Walker is a social science researcher and research fellow with a background in nursing, youth work, and community development. And her research is focused on understanding the lived experience of criminalised and marginalised populations. Dr. Michael Curtis is a research fellow and public health researcher whose work focuses on the intersections of drug use, incarceration and health equity. And Emmanuel Mamiotti is a PhD candidate whose work primarily focuses on the impact of law enforcement on the health and social outcomes of people who use drugs. So thank you all so much for joining us today. We're really grateful for your time and all the energy that you put into preparing these presentations. I'm going to hand over to the three of you now. First up with Shelley. Yep, your present slides look great, Shelley. And after the three presentations, we'll then have the Q&A session. So don't forget to put any Q&A questions you have in that Q&A box. Over to you. Thank you so much.
Thanks, Steph. We're on the acknowledgement of country slide. Yes?
Yep.
Thank you. Thanks for that lovely introduction. I too would like to acknowledge the Wurundjeri people of the Kulin Nation as the custodians of the unceded land I'm presenting from today out in the Dandenong Ranges to the east of Melbourne. I'd also like to acknowledge the traditional custodians of the unceded lands across Victoria where this research I'm talking about today was conducted, and pay my respects to elders past and present, and I'd like to extend that respect to any Aboriginal and Torres Strait Islander people joining this webinar today. And just to acknowledge this beautiful artwork here on the slide is by Stacey, a Toonarong Boonwurrung artist who was a participant of the Torch, an Aboriginal-led arts and cultural support program for Aboriginal people in prison and in the community after their release from prison. This artwork was commissioned for our Reconciliation Action Plan at the Burnett Institute in Melbourne, where Michael, Emmanuel and I are co-located. And this is Bunjil, the wedge-tailed eagle, who is the caretaker of the Kulin Nations. So when we talk about the harms associated with methamphetamine use, we often think first about its effects on people's physical and mental health, on their relationships, their families and their everyday lives. But what I'm going to focus on today is a different set of harms. It's those that can arise from the way we respond to methamphetamine use, particularly through criminalisation. And by criminalisation, I mean responding to drug use through criminal laws, and the criminal legal system through things like policing, the courts, and corrections. And specifically, I'm focusing on what that can mean for people living in rural and regional communities. So, Australia has relatively high levels of methamphetamine use compared with many other countries. Crystal methamphetamine, or ice, is now the most commonly used form of methamphetamine in Australia, and smoking is the most common way it's used. But importantly, methamphetamine use isn't evenly distributed across the population. We know that use is higher among people experiencing social and economic disadvantage. And just to clarify, when I talk about methamphetamine or use the term methamphetamine throughout the presentation, I'm actually referring to crystal methamphetamine. So, methamphetamine use and possession are criminal offences across most Australian jurisdictions. And just to give a little bit of context for what this means in Victoria, where the study was conducted, methamphetamine use can actually carry a maximum penalty of around $6,000 or 1 year in prison or both. So, people's methamphetamine use is occurring within this legal environment in which drug use and possession can bring them into contact with police, courts, and corrections. Living in, as I mentioned, living in rural and regional communities can also shape the experiences of people who use methamphetamine. There can be much less anonymity, which means people and their reputations can be more highly visible. And we also know that in rural and regional areas that access to health and social services can be much more limited. So it's at the intersection of these three things, methamphetamine use, rural and regional place, and criminalisation, that my presentation's focused, including in particular what happens when these things come together in the everyday lives of people who use methamphetamine. So the narratives I'll be sharing come from a qualitative study that involved interviews with 23 people who smoked methamphetamine and lived in rural and regional Victoria. They were recruited from the VMAX study, which is a long-running Victorian cohort of people who use methamphetamine, which Michael and Emmanuel are going to be speaking about after me. Everyone we interviewed had some previous contact with the criminal legal system, including experiences of police arrest, police custody, detention, and or incarceration in adult prisons or youth detention facilities in their teens. The interviews were really broad and explored people's experiences of drug use, their interactions with police and the criminal legal system, their housing and financial situation, and their experiences of stigma and discrimination and access to health and community services. I'm going to share a little bit about who took part in the study, and then I will focus on some of the narratives that emerged from the interviews. And just to note that all of the participant names have been replaced with pseudonyms to protect their identity. The 23 participants of the study were aged between 23 and 49, and 4 identified as Aboriginal. And as you can see here, many had experienced significant social and economic disadvantage, including half who had experienced homelessness and reliance on income support was really high too. And almost half had been incarcerated as an adult or child, or both. In terms of the reasons participants used methamphetamine, and I'm just providing this for a little bit of context, none talked about their ongoing use as recreational. Most described it as a mechanism to cope, and whether that was to deal with depression and anxiety or trauma and grief, or simply to give them the energy and confidence to get through the day. And many said they used methamphetamine as self-medication for ADHD. So for most participants, their methamphetamine use was occurring in this context of substantial health and social challenges. In terms of people's current use, most were using daily at the time of interview, and just under a third had stopped using, including a few participants who had stopped using more than a year ago. So One of the things that was common across the narratives was that most were very critical of their own drug use. They talked about methamphetamine as destructive, difficult to escape, and something they wished they'd never started using. So they weren't dismissing or minimising the harms associated with their drug use, really. For example, Jaden said, "It's shit, man. It'll ruin every life it touches, even the lives of those who aren't using." And Dana here said, "I hate it. I wished I'd never touched it. It's not even about the high anymore. It's just to feel normal, but it's wrecked everything, family, work, everything." But as I said, what I want to focus on now are some of the other harms they described, harms arising from how other people and particularly systems responded to them. So participants talked about the lack of anonymity in small towns where people often know one another, reputations can travel quickly. And once someone became known as a person who used methamphetamine, that could be very difficult to escape. Greg described it really simply. He said, "I just feel like I've got 900 eyes on me. People know, they're not stupid. You can't hide in a place like this." And Tom made a similar point when he said he'd rather live in suburbia where he could just be a fly on the wall. So methamphetamine use wasn't simply something somebody did, it became part of who they were understood to be. And that same visibility extended to policing. So participants talked about being repeatedly stopped, searched, and drug tested by police once they became known as someone who used methamphetamine, including at times when they weren't even using drugs. Janie talked about how even, years later, a drug-related police record continued to follow her. She said, "I've only ever had drug possession charges. There's never been any selling or anything like that. I've never stolen anything from anyone to feed my drug habit. I had money saved, so it wasn't like I was involved in that kind of criminal activity. So all my police record shows is using drugs. But that police record, I believe, still to this day gets me pulled over by the police and drug tested." So here, the effects of criminalisation didn't necessarily end with the original offence. Once someone became known to police as a person who used drugs, that identity could stay with them, shaping how they were seen and treated for years afterwards. For Aboriginal participants, experiences of drug-related surveillance also intersected with experiences of racialised policing. David, for example, described being repeatedly pulled over and questioned, including at times when he had nothing on him. He said, "They always pull me over and ask me, 'Where are you going? What are you doing out at this hour?' And these are times I've had nothing on me." So for Aboriginal participants, their experiences of methamphetamine-related policing were occurring in addition to experiences of racialised policing, which made surveillance even more difficult to escape. But it wasn't only police interactions where people experienced this kind of judgment. People described being watched, refused services, and judged in public. Some people described how they withdrew from community life to avoid judgment and humiliation. As Sarah describes here, that could become incredibly isolating. And sometimes returning to the drug using scene felt easier because it was familiar and comfortable. She said it can be very isolating and lonely. It's so much easier sometimes just to go back into that scene where you know it's comfortable. And Jaden made the important point that you can be a good person and still be an addict. He said there's stigma around it and people just look, pointing fingers. You're frowned upon. You've only got to look at a post on Facebook, some misdemeanor offence or something, and you get umpteen comments. "Oh, fucking crackhead this, crackhead that, blah, blah, blah." Like you can be a good person and still be an addict. So stigma and exclusion weren't just unpleasant experiences in themselves. They could leave people feeling isolated from the broader community, while the drug using networks they were trying to move away from could remain one of the few places where they actually felt accepted and comfortable. And in that way, stigma could actually contribute to the conditions that made changing drug use harder. Participants talked about how an initial possession charge, as I mentioned earlier, a relatively minor offence could become the beginning of repeated contact with police, courts, and corrections. In rural areas, correctional community corrections requirements could also be particularly difficult to meet because of the distance and limited transport. Nick's account here shows how relatively minor breaches could pull people further into the criminal legal system. He'd stopped using and was complying with his community corrections order, but was breached after being late for an appointment. As he described it, I was doing my hours and going to all my appointments, and I was actually still trying to be clean. But he was late to one of his appointments. He said, I rang the corrections officer and told her I was late, but she still breached me. I had to go back to court. It got me back into that state of mind where I was like, fuck it. And he used. So rather than supporting his efforts to move away from drug use, that experience contributed to pulling him back into the cycle. While the criminal legal system was a really significant presence in participants' lives, health and social support often wasn't. Many described limited drug treatment options, long distances to get to services, and practical barriers like not having a car or money for petrol, and limited public transport options that sometimes they couldn't afford. And seeking help was something that was described as making people more visible and open to stigma. Kylie, for example, said, a lot of people that do the drugs here don't access services because of the stigma, because it's seen as a criminal thing, not a mental health thing. So there's a real contradiction here. Participants described a system that was very good at policing, monitoring and punishing them, but much less able to provide the care and support they needed. And in finishing up, I just want to leave you with three key things or points. First, that participants' experiences show how criminalisation can compound rather than reduce harm, particularly when it intersects with rural disadvantage, stigma, and limited access to support. Second, I think, importantly, we need to shift the gaze from suspicion to care. And that means thinking about how we respond to people who use methamphetamine in ways that don't further stigmatise, exclude, or criminalise them. And making sure that when people do want support, that support is actually accessible, but particularly in rural and regional communities. And finally, if we want to reduce methamphetamine-related harm, we need to prioritise harm reduction, support dignity and respect over punitive responses. And that also means being prepared to question whether criminalisation is actually achieving what we wanted to achieve, particularly when participants' accounts show how it can create additional harms of its own. I would like to finish up by acknowledging and thanking the VMAX participants who participated in the interviews so openly and honestly. And I would like to thank Zoe Gleason, who did some of the coding of the data, and the Burnett Institute field workers who supported recruitment. And that's it from me. Thank you.
Great. Thank you so much, Shelley. I'll now hand over to Michael to give his presentation. He's probably just working away, getting up, and here we go. Thanks, Mike.
Hello, everyone. Sorry, just working out controls. I think my slides are sharing. I'm on screen and my microphone is working, so we're off to a good start. Thank you, Steph, and thank you, Shelley, for that great presentation. I too would like to just start my presentation by acknowledging that I'm on the lands of the Bunurong people. They're the traditional custodians of the lands and waters that I both live and work. And I pay my respect to their elders, past and present, and extend that respect to all First Nations people who have joined online today. So there's approximately 200,000 people, or 1% of Australians, are estimated to have used methamphetamine in the last 12 months. And although most people who use methamphetamine will not experience significant adverse consequences, regular methamphetamine use is associated with an increased risk of several adverse outcomes, including methamphetamine dependence, poor physical and mental health, poor health-related quality of life, and premature mortality. And as many will here will be aware, and that Shelley's just discussed, drug law enforcement remains a primary policy response to methamphetamine use and attempts to reduce methamphetamine-related harms in Australia. And as a result, people who use methamphetamine are overrepresented in Australia's prisons. For example, despite approximately 1% of the general Australian population being estimated to have used methamphetamine in the last year, recent estimates suggest that almost half of people in prison will have used methamphetamine in the year prior to their imprisonment. And for people who use methamphetamine, imprisonment is associated with a range of adverse outcomes that include, but certainly aren't limited to, an increased risk of death on release, disconnection from their family and community and from health and support services, and deteriorations in physical and mental health, and experiences of unemployment and homelessness are also common upon release. And while there's research describing the overrepresentation of people who use methamphetamine in prison and the harms they may experience during and following imprisonment, to date, there have been no prospective Australian studies examining rates and correlates of imprisonment amongst community-recruited cohorts of people who use methamphetamine. Prospective studies, that is, studies which follow people over time, can be useful to identify factors which may predict future events such as imprisonment, thereby providing evidence to inform targeted interventions to reduce imprisonment amongst people who use methamphetamine. Accordingly, in this study, we aim to estimate how often people who use methamphetamine regularly are imprisoned and what factors may increase or reduce their risk of imprisonment. And so to do this, we use data from the VMAX study, the same study that Shelley's just mentioned. And so this is an ongoing prospective cohort study of people who primarily smoke methamphetamine, which is run by our collaborators at the Burnett Institute and Monash University. VMAX recruits people from Melbourne and 4 areas of regional Victoria. Study commenced recruitment in 2016 and is ongoing to this day. And at the time of this analysis, 808 participants were enrolled in the study. VMAX eligibility criteria included being at least 18 years of age, using methamphetamine at least monthly for approximately 6 months, primarily by non-injecting routes, and also having the ability to provide informed consent. And participation in the study involved a regular interview. So for the first few years, this was every 6 months, but from, I think it was COVID on, the interview reverted to an annual interview, which covered things like demographics, drug use, criminal justice involvement, and engagement with health and drug treatment services. So the outcome for this study was a binary yes or no response, indicating whether someone had reported being imprisoned at least once since their last VMAX interview. We calculated imprisonment rates by dividing the number of interviews where imprisonment was reported by the total time people spent participating in the study. And we then explored whether a range of demographic, substance use treatment, and behavioural factors were associated with subsequent imprisonment using a mixed effects, multiple event, discrete time survival analysis. What a mouthful. That is to say, we explored whether these factors measured at one interview were associated with imprisonment in a following interview. So hopefully capturing sort of some of that predictive effect. We only included participants in the analysis who had completed at least 2 VMAX interviews. So we had a period between at least 2 interviews to observe whether people were imprisoned, and then also restricted that to people who had complete data. So of the 808 VMAX participants, a total of 539 had completed a baseline interview and at least 1 follow-up interview and had complete study data and were therefore included in the analysis. These participants contributed just under 2,300 interviews, equating to more than 2,200 person years of observation. And at baseline, participants included had an average age of 37, just over a third identified as female or non-binary or another gender, and 4 in 5 were using methamphetamine at least weekly. So we found that 118 people were imprisoned at least once during VMAX, and these 118 people contributed a total of at least 168 interviews that included at least one episode of imprisonment. And this produced a very conservative crude imprisonment rate of 74 imprisonment episodes per 1,000 person years of observation. And in our adjusted analysis, we found that people who identified as either female or other non-binary gender identities and people who were employed were at lower risk or hazard of future imprisonment, while people who lived in medium and small rural towns, people who use methamphetamine at least weekly, that's compared to either no use or less than weekly use, and people who had previously been to prison as an adult were at an increased hazard of future imprisonment. Experiencing homelessness, injecting drug use, and recent participation in methamphetamine treatment were not associated with an increased or reduced hazard of imprisonment. And for Aboriginal people, while the hazard of imprisonment was 70% higher than their non-Aboriginal counterparts, this difference was narrowly not statistically significant. So we found that just over 1 in 5 participants reported being imprisoned during VMAX study follow-up at a rate of about 74 imprisonments per 1,000 person years. And although most VMAX participants were not imprisoned during the study, our observed crude imprisonment rate was more than 30 times greater than the imprisonment rate for the general Australian population. And our study findings point to several areas where targeted interventions may help to reduce these high rates of imprisonment among people who use methamphetamine. And given the time constraints that we have, I'm just going to focus on 2 of these findings. So the strongest predictor of future imprisonment in our study was a history of previous imprisonment with people who had previously been to prison before being recruited into VMAX, on average having a almost 3 times greater hazard of subsequent imprisonment. This suggests that sending people to prison is unlikely to address the environmental, behavioural and structural factors which contributed to their imprisonment, and that alternative responses to methamphetamine-related offending are needed. Acknowledging that we don't know why the people in this study were imprisoned at this point in time, we'll get some linked data for the cohort in the next year or 2. But in Victoria, as Shelley pointed out, it's quite possible that some people in this cohort were imprisoned for methamphetamine use or possession. Given the growing body of research which shows that criminalisation of drug use doesn't deter drug use and can impede housing and employment opportunities, decriminalisation of methamphetamine use and possession should be considered. Further, non-custodial options such as community-based treatment typically facilitate better health and recidivism outcomes than imprisonment, and these kinds of responses should be prioritised for non-violent methamphetamine-related offences. And in situations where people who use methamphetamine are imprisoned, improved access to evidence-based in-prison and post-prison release supports, which facilitate timely access to safe and secure housing, training, employment, and health and social supports, are desperately needed to help people to break cycles of re-imprisonment. We found that weekly or more frequent methamphetamine use was also associated with an almost 70% greater hazard of subsequent imprisonment compared to people who are using less than weekly or not at all, pointing to a need for increased access to treatments and initiatives which support people to reduce their methamphetamine use. However, we also found that participation in drug treatment in the 12 months the interview before the imprisonment was observed was not associated with subsequent imprisonment. And there's several possible explanations for this. That our measure of treatment access does not capture whether treatment was completed, and it also combines several forms of treatment into one variable. Studies from New South Wales have shown that about only half of treatment episodes for amphetamines are completed, and that some treatment modalities, such as detox, are less effective than rehabilitation programs, particularly when rehabilitation programs are combined with additional psychosocial supports. These findings also need to be considered in the context of Australia's broader treatment landscape. Unlike treatment for opioid dependence, alcohol dependence, and tobacco dependence, there are currently no approved pharmacotherapy options for treating methamphetamine dependence. Although some recent research from Rebecca McKetton's group has found that metazapine is showing some promise. And we also currently lack contingency management, and this has the strongest evidence base for reducing methamphetamine use. As with all studies, there are several limitations to this work. Our imprisonment outcome, because of the way the survey was constructed, was restricted to a binary measure, so we don't know whether people who went to prison during an observation went just once, or they may have been multiple times. And as a result, this has led to some fairly conservative assumptions in order to calculate the imprisonment rates. And it's quite possible that the imprisonment rate is actually higher than we've calculated. Where there's also a number of other limitations related to attrition bias, the generalizability of these results to other jurisdictions, and limitations of self-report data. So just to wrap up, we found that 20% of a cohort of people who regularly use methamphetamine, primarily by non-injecting routes, were imprisoned during the study observation, some imprisoned multiple times. And this has occurred at a rate of more than 30 times than the general Australian population. And initiatives which reduce recidivism and novel treatment modalities are desperately needed to support people to reduce their methamphetamine use and reduce their exposure to imprisonment. I would just like to finish up by acknowledging some people. Firstly, the more than 800 people who've participated in the VMAX study between 2016 and today. My many co-authors there, my colleagues at the Burnett Institute and Monash University in the fieldwork team for their tireless work following up study participants, and for the various funders of the VMAX study over the years. There are some references there. And that's it from me. Thank you very much.
Thanks so much, Michael. That was really interesting and appreciate you sharing all that research. I'll now hand over to Emmanuel for the last part of today's presentation.
Thanks, Steph. I'll just share my screen. I trust that's showing up fine for everyone.
Looks good.
Okay, thank you. So I'd just like to start by acknowledging my supervisors and co-authors for this paper. They're listed here. I'd also like to acknowledge the traditional custodians of the land on which I'm on, which is Darug land. And I'd like to pay my respects to elders past and present. So just an overview of what I'll be covering. Firstly, I'll be covering some of the background and context for this study. Basically, the state of methamphetamine use and harms in Australia, and the disadvantages of people who use methamphetamine. Some of this has been covered already by Shelley and Michael. Also, how law enforcement involvement relates to this population. Then I'll briefly touch on the methods we used for this study. And then I'll share our main findings and discuss some implications. So a lot of this has been touched on a bit already, but about 1% of the Australian population over the age of 14 reported past year methamphetamine use in 2022 and 2023. Amphetamine and other stimulant hospitalizations peaked in 2019 and 2020, and 81% of these were methamphetamine related. This has now decreased and stabilized over recent years, but between 2001 and 2020, there's been a long-term uptrend in methamphetamine related deaths. We think that these harms are underpinned by large changes in the methamphetamine market. Basically, purity adjusted price has declined, so you can get higher purity methamphetamine for a lower price. and consumption levels among people who use methamphetamine have increased. So again, this will be common knowledge by now, but existing literature highlights the vulnerability of people who use methamphetamine. See a disproportionate level of physical and mental health conditions, housing instability, and barriers to employment. So among people who use methamphetamine, 74 to 89% of people in an Australian community-based cohort study reported unemployment. So that's just one statistic that explains this level of unemployment in this population. We also know, so we know that the employment outcomes for this population are generally poor. But what we're interested in with this study that I'm going to present the findings for is that whether law enforcement further impacts these outcomes. This is relevant due to the high rates of law enforcement involvement among people who use methamphetamine. Methamphetamine was actually the most commonly used drug amongst police detainees at police stations in 2021, with 50% testing positive for methamphetamine. So this is an example of the overlap between people who use methamphetamine and those involved with law enforcement, whether that be arrest or incarceration. So we're looking to what extent compounding disadvantage is present at this intersection with methamphetamine use. This brings us to our study, which is where we did an examination of the associations between arrest frequency and changes in employment among people who regularly use methamphetamine. So this has already been covered very well by Michael and Shelley, so I won't dwell on this too much, but we collected our data from VMAX as well. Yeah, I don't think there's anything else I had to add here. This was covered very well. Interviews approximately 45 to 60 minutes, and they're occurring annually now. So this longitudinal data is very useful for our study, where we wanted to look at employment changes between interviews and see how that relates to participants' number of arrests within these two interviews. So each participant's number of arrests was self-reported. So we basically a question asking how many times since we last saw you have you been arrested. We then categorize the amount of arrests into these three groups you can see here. So no arrest, a single arrest, or multiple arrests, which was 2 or above. We did this mainly to reduce recall bias. As you can imagine, over a 12-month period, especially if you've had many arrests, it might be difficult to recall an exact amount of arrests. So this categorization was done to mitigate this error. Sorry, that should say employment, not housing. Employment was a yes/no indicator based on the participants' reported employment. And then change in employment was determined by simply comparing a participant's employment status at their previous interview to their current interview. So for people interested, this is a flow diagram of how we arrived at the final sample. And as you can see, we ended up with a total of 646 participants included in our analyses. So of these 646 participants, 44% reported employment at any stage during BMAX. So over half were never employed during the study, and almost all the participants, so 92%, reported unemployment at least once during the study. 57% of participants reported at least one arrest during the study, with 43% never reporting arrest. So to put it simply, our analysis was two logistic regressions to look at the factors that were associated with these two scenarios. Essentially, one looking at gaining employment and one looking at the loss of employment. These are the covariates we used, the other factors that we accounted for apart from arrest. Basically, the frequency of methamphetamine use would be a big factor here, but all of these have prior literature showing that they are related factors to employment. So here are the results. So first we'll start with the transitions from unemployment to employment. We had data from about 2,200 observations where people reported being unemployed in their last interview. Out of these, participants gained employment 14% of the time. On the right, we have the results from the analysis. So just looking at arrests, a single arrest didn't really have any association with gaining employment. However, being arrested multiple times did have this association with a reduced likelihood of gaining employment compared to having no arrests. So moving on to the opposite direction, so becoming unemployed, we had data from 947 observations where people reported being employed at their last interview. And out of that, participants moved to unemployment by their next interview 25% of the time. So we found that having a single arrest increased the odds from going into unemployment from employment, and so did multiple arrests. If you look at the table and then the column that says adjusted odds ratio, the OR there, it shows what we're expecting. Basically, if a participant was arrested more times, they were more likely to lose their employment. Here is essentially the same results for the visual learners. You can see that participants were less likely to get employed with multiple arrests and more likely to lose employment with multiple arrests compared to just the one arrest. So there were some limitations. So as you can imagine, self-reported data isn't always the most reliable. So that was one limitation of the study. We hope to run these analyses with visual link data soon, as Michael was mentioning. Data about informal work, employer factors, and hours worked weren't captured in these interviews. So these would have been factors that conceptually would be included as covariates to account for, but these weren't captured. Of course, we can't account for everything, but still our results should be interpreted with this in mind. Another thing is that the employment transitions were only captured at the interviews. So any extra transitions in and out of employment would not have been captured in our analyses. So just some implications. We can think of a few possible ways by which arrest could affect employment outcomes. One is that employers are less likely or less willing to hire individuals with a criminal record. There's a case that received a bit of media attention in Canberra where a job offer was rescinded after the employer learned of the applicant's criminal record. And we know that a stigma like this actually impacts people's attitudes towards looking for work. For instance, Research in Queensland found that the stigma related to people's criminal records was a big barrier to job seeking post-prison release. Even beyond criminal records, each arrest triggers a process by which an individual is required to go through police processing and court dates. This adds a further risk of arrest for failure to comply with these obligations. So for someone already unemployed, it's possible that this would demand a lot of time and effort, which could otherwise be used to seek employment. And this is where this compounding effect comes in, like we saw in our results. And as Shelley touched on earlier, a single arrest did not on its own reduce the likelihood of subsequently reporting employment. However, multiple arrests did. What we do know is that the results highlight a need for utilising diversion programs, reforming policies around criminal records, and the further development of employment support programs for individuals that fall into this population. Thank you.
Great, thank you so much, Emmanuel. And welcome back to all of our presenters. That was a really interesting conversation and about a really complex topic, and we've had some questions come in. One of the first questions that's popped up is just around the VMAX cohort itself. So you said that it primarily focuses on smoking, and someone was wondering why injecting drug users weren't included as part of the analyses. So Shelley and Michael, perhaps you could speak to that.
Yeah, I can field that one. So there's a couple of reasons, one pragmatic and one's a little bit more, I guess, data-driven. The pragmatic reason is that our colleagues at the Burnett Institute had already been running a prospective cohort study that focused on people who injected drugs since 2008. So that's the Supermix study. If you Google Burnett and Supermix, that study will pop up. It'll be the first thing that shows there. And that study today has, I think it's 2,500 people who regularly injected drugs involved in that cohort. But from, I guess, a bit more of a data-driven point, there's other research around that shows that people who inject drugs are a little bit older tend to inject amphetamines in combination along other drugs as well, and they're generally an older cohort engaging with needle and syringe programs, things like that. And there's been a lot of research over the years about people who inject drugs, much less so about people who are using methamphetamine by non-injecting routes, who we think have less contact with harm reduction services, potentially younger. And so that's what this study set out to do, was to fill this gap about what do we know about people who don't inject their amphetamines.
And I think...
Anything to add, Phil?
Just going to say that we also know that smoking is the most common route, which I think a few of us have mentioned in their presentations, of administration. So it's really about capturing people who smoke methamphetamines, distinct needs and issues.
Yeah, and I guess there's a lot of different health outcomes for people who smoke versus injecting, a lot more complicated factors. What impact, if any, does mental health sort of evidence have on sentencing? Is that anything any of you can speak to or are familiar with? No?
Sorry, no, I wouldn't want to comment on the specifics of sentencing practices and mental health considerations. But it's a good thing for me to have a read on.
Yeah, fair enough. I guess because there is so much co-occurring mental health and methamphetamine use, it is a bit something that people are quite interested in. Is there any way to track the usage and method before, during, and after imprisonment? or is it still just a bit of a grey area when it comes to data collection?
So I'm happy to field that one. The We could potentially do methamphetamine use before and after imprisonment. VMAX didn't allow us to go into prisons to do interviews with people while they're in prison. What I would direct, I think that question's come from Jess Stowe. Jess, if you're interested in this, if you Google a paper called It's High Resumption of Injecting Drug Use, and put in Curtis as well. That was a paper from my PhD. So this was from a different cohort of people who regularly injected drugs immediately prior to imprisonment. The most commonly used drug in that cohort was methamphetamine. And so that paper actually looks at drug use before and following imprisonment, and shows really high rates of return to injecting in the days and weeks following release from prison.
And Emmanuel, one for you. Were you able to determine the proportion of people who were able to actually maintain employment, particularly those who were actively using the drug?
So this was really just a associations paper. So we haven't looked at any trajectories yet in any detail. It's definitely something we want to look into though, but thanks for the question.
Yeah, no worries. And you also mentioned diversion programs. So I understand that every state and territory has a diversion program. Is that correct? Do you know what the barriers to sort of those being applied are? I can throw that open to Michael as well.
Yeah, I mean, just on the knowledge I have, and the research I've seen is that some of these diversion programs are a bit underutilized, especially in the context of methamphetamine. So I was just really speaking to that fact. Not sure if any of the others had anything to add.
Yeah, I'd love to know if we know any of the reasons why they might be. Is it purely because methamphetamine is often a lot more stigmatized than other drugs? Or, yeah, do we think there are any particular reasons why they're not being applied or utilized as much?
I myself, I'm not too sure on the reasons. Yeah, I'm not sure if Michael or Shelley wanted to comment.
No, and I'm frantically trying to Google. There was some work presented at the ISSDP conference that I think was coming from someone at Flinders University. I'm really apologetic if that person is on the call. And I'm forgetting who that was. But there's been some great work that I know is in progress at the moment looking at access to diversion programs, both across Australia and at particular jurisdictional levels. I think there's lots of issues around eligibility, around police actually offering those to people. They're not necessarily formalised as a compulsory part of the judicial process as well.
Yeah. Anything to add, Shelley?
Not really. I mean, it's not something I think too, it's about, law enforcement knowledge about programs, being actually knowing that they exist and what it means. I think there's evidence that that's been a real barrier in their implementation too.
Yeah. And so is the VMAX study still continuing? Is it collecting data? What kind of phase is that study in? I can see Michael still furiously typing, looking for his PhD paper, no doubt.
No. Someone's very kindly put that in the chat for me. I was just responding to another question in the chat. VMAX is very much still ongoing. So recruitment continues to happen in Melbourne and 4 regional areas around Victoria. We're still taking new participants and still continuing to follow up currently enrolled participants as well.
Yeah, great. And what do you think is next steps in terms of the where you want to take this sort of data analysis and the project findings to date? Emmanuel,
Uh,
what? Oh, you go, Michael.
no, I was just going to say, and this might help answer a couple of questions in the chat as well that have asked, been picking up on kind of the gap that Emmanuel and my work in particular has, where we don't actually know what the offences were. So at the moment, we are seeking permission from participants to access administrative records from Victoria Police and Victoria Corrective Services. So we'll then have this objective measure of why people have been to prison and for how long they've been to prison for. And so we're hoping to submit that data request probably in the next 12-ish months. So there'll be a little bit of time then for the data to come through, but then we'll be able to start filling some of these gaps as well, to look at why people are being involved in the criminal legal system.
Can I make, sorry, just a quick, I've just
Yeah.
up on the chat, the Q&A. It's so lovely to see so many questions. People are so engaged with, this topic. And I've just noted, I'm not sure if I'm pronouncing it right, Nakia Bunham. Are there any opportunities for people with lived experience to contribute to this research or any future studies? And I want to just say what a really valuable point that's being made there. I should have said this work that I was doing is from previous to a study I'm focused on now, which is about young people's experiences of police custody, including young people. I've interviewed young people who do use and have used crystal methamphetamine. But I think that's a really important point that we're doing a whole lot of work at the moment, increasing opportunities for people with lived experience to be involved in the work that we do. And I'm not sure who that person is, but happy for them to reach out and something for us to be really thinking more about how we can do that. So thanks for that.
Yeah, involving lived experience is such an important and invaluable asset to any research project. There's also a fair bit of questions and answers around the treatment options. And I know that you touched very briefly on this, Michael, around how there is some promising pharmacotherapy work being done. And I know Rebecca McKeaton at the National Drug and Alcohol Research Centre and the NCRED, National Centre for Emerging Drugs, doing a lot of promising trials around this. Is there any sort of barriers to treatment or anything that popped up in your data for people who had been exposed to the criminal justice system? Does that create an additional barrier to them being able to access treatment?
I think Shelley's work in the first presentation highlighted that some people are quite reluctant to engage with treatment as it does risk getting involved, whether actual or perceived, becoming involved with the criminal legal system. Then it can, there's also where people are involved and then become involved with involved with treatment, then get involved with the criminal legal system, particularly if they end up imprisoned. This fractures all kinds of care relationships. There's wait times, there's questions of quality and access to service around and access to particularly to evidence-based treatments within the prison systems as well. And of course, for Aboriginal people who we know are dramatically overrepresented, there's also issues of cultural safety and cultural appropriateness of drug treatments that are being offered in prison. But I will give a shout out to Michael Doyle's group at UNSW, who are doing some great work in that space.
Yeah, great. Well, I think that's pretty much all that we have time for. Thank you so much for a really engaging presentation. As Shelley said, there's so many questions that have popped through. And please feel free to email us if you haven't had the opportunity to have your question answered today. Thank you to all the presenters for sharing your valuable insights. Is there anything else that you'd like to add before we finish up today?
I just wanted to say there's lots of unanswered questions in the chat, and just for people to our email details, people can have access to our email.
Yeah, we can do that for sure.
Directly. I've just spotted some more questions about lived experience involvement, and I'm really happy for people to get in touch with me. Thank you everyone for listening and being here. We really appreciate it.
Yeah, and thank you so much for your time. We really appreciate you sharing your expertise and yes, fielding all the tricky questions. It's great when we have such a engaged audience. It's helpful to know what people are really keen on hearing more about. So just to wrap up today, we will be holding more webinars and putting more resources on Cracks in the Ice throughout the year. So please subscribe to our mailing list to receive future updates. We will let you know when the recording for today's webinar is available. And we also would greatly appreciate it if you could take a minute to complete our short survey that will pop up on your screen at the end of the webinar. So thank you again, everyone, for joining us. And thank you to our presenters, Emmanuel, Michael, and Shelley. And I hope you all have a lovely rest of the day. Thank you, everyone.